So now moving on to a proper topic, which is genital herpes in pregnancy. So in this we will be dealing with what if a pregnant woman acquires the infection in the first trimester, second trimester, third trimester. How will you manage the women in during labor, and how will you manage the baby? So these are the under these topics we will be discussing this lesson. So the first thing is how we are going to manage a patient who is positive for herpes infection in the first and second trimesters, that is before 28 weeks. If she gets herpes infection, the risk of transmission to the fetus is very low, but however you have to treat this active lesion by giving tablet acyclovir 400 mg TDS for 5 days. So you have to give this tablet for 5 days. After that you have to give the second dose, which is actually called as we'll give this dose to reduce the asymptomatic viral shedding. That is, you will give 400 mg 3 times a day from 36 weeks until delivery. So first thing is, as soon as you have found out the patient is having herpes, you are going to treat her with acyclovir, followed by from 36 weeks to prevent this asymptomatic viral shedding, you are going to give 400 mg 3 times a day from 36 weeks until delivery. So usually acyclovir is safe in pregnancy. There are some reports which say causes transient neonatal neutropenia, but it is very low. It's around 10 to 1%. So generally it is safe in pregnancy. And can we allow normal vaginal delivery to this patient? So patient is coming to you, she has a history of herpes infection in the first trimester, around 10 weeks, and she has been actively treated with acyclovir. And what will you advise the patient? She can be led for normal vaginal delivery unless and until there is no obstetric indication for a cesarean section. You can allow the patient for a normal vaginal delivery. So you can give a try of normal vaginal delivery. The risk of transmission to the fetus is low. So you have to assure the patient that if she getting a herpes infection, the risk of transmission to the fetus is very low. Now what happens if the same patient is getting the herpes infection, the primary herpes infection? So primary herpes infection in the third trimester is very risky. There is increased risk of perinatal morbidity, there is increased risk of preterm labor and low birth weight. The treatment is same. You give the patient the tablet acyclovir 5 days 3 times a day, followed by again from 36 weeks you will give until delivery. And in this case the difference is that you have to leave the patient for cesarean section because third trimester there is high risk of neonatal herpes. So you have to do a cesarean section should be preferred, and the patient should also be counseled regarding the need for cesarean section in case of a herpes infection when the patient is acquiring in the third trimester. So this both conditions is about primary herpes. If she is getting the herpes for the first time, if she is getting it in the first trimester and second trimester, nothing, she is okay, you can leave her for normal deliveries, treat her with acyclovir and leave her for normal deliveries. But if she is getting in the third trimester, you have cesarean section is preferred and the usual treatment with tablet acyclovir, and you have to counsel the patient there is increased risk of low birth weight, perinatal mortality and morbidity is also high in this case because the transmission to the fetus is around 40 to 45%. So this is in general if the patient is getting a recurrent infection. So in this case the IgG is positive. So in that case the risk of neonatal herpes is very low because already the mother is having IgG antibodies and that have been passively transmitted to the baby through the placenta. So the risk of neonatal herpes is very low. The recurrent lesions usually they resolve within a week or two without any antiviral treatment. There is no need of active antiviral treatment. So they are self-resolving and they resolve around 7 to 10 days. But you have to give a suppressive acyclovir from 36 weeks, as same as primary lesions to prevent the shedding and everything. So you have to give a suppressive dose. Vaginal deliveries can be preferred, and also the risk to the baby is also low. Usually recurrent infections they resolve beautifully.